So hi, everyone. My name is Danai Dima. I'm a third-year hematology oncology fellow at Cleveland Clinic. And today I'm going to be presenting our job that was presented at ASH of 2023 with the title Real-World Safety and Efficacy of Teclistamab for Patients with Heavily Pretreated Relapsed Refractory Multiple Myeloma. So basically, this was a multi-center retrospective study with the aim to assess the real-world efficacy and safety of teclistamab in patients with relapsed refractory multiple myeloma. We included a total of 106 patients from 5 U.S. academic institutions who received standard of care teclistamab. Just to give a little bit of background about teclistamab, so teclistamab is a BCMA targeting bispecific antibody that was approved by the FDA in October of 2022 for the treatment of relapsed refractory multiple myeloma based on the results of the phase 2 MajesTEC-1 trial, which demonstrated its efficacy and safety in patients after at least 3 prior lines of therapy. Like many other landmark registration trials, the MajesTEC-1 implemented strict eligibility criteria. Patients enrolled in this trial were not reflective of the broader real-world patients that we treat in clinic, who typically present with significant comorbidities, organ dysfunction, severe cytopenias, and prior exposure to BCMA-directed therapies. And also these patients that we see in clinic, they have pretty high-risk disease features. And all of these would have made these patients ineligible for the trial. For this reason, we felt it's crucial to investigate the real-world utilization patterns of teclistamab and evaluate its outcomes in high-risk patients who would have been considered ineligible to receive teclistamab in a clinical trial. So our study included, as I previously said, 106 patients. So among these patients, 83% would have not met the inclusion criteria for the MajesTEC-1 trial. Most common reasons for trial exclusion were receipt of prior BCMA-directed therapy in about half of our patient cohort, severe baseline cytopenias and poor performance status in about 1/3 of our cohort, and also renal dysfunction in about 13% of our cohort. Other reasons were presence of liver and cardiac dysfunction, plasma cell leukemia, and central nervous system involvement. All these were present in lower rates. Notably, around 40% of the patients met 2 or more of the exclusion criteria. Another hallmark of our study was the inclusion of a high proportion of patients with high-risk disease features. So specifically, 64% of patients exhibited pentaclast refractory disease, around 60% had high-risk cytogenetics, and around 40% had extramedullary disease, and about 1/3 of our patients were older than the age of 70. In addition, 1/3 of our study participants were minority patients. So all these high-risk features were seen in much higher proportions in our population compared to the MajesTEC-1 trial population. So overall, teclistamab appeared well-tolerated and relatively effective in a real-world heavily pretreated patient cohort. The overall response rate was 66% and was comparable to the 63% seen in the MajesTEC-1 trial. So the overall response rate in patients with high-risk cytogenetics, pentaclast refractory disease, and age older than 70 years remained high. And it was actually 63%, 71%, and 68% respectively. However, in patients with extramedullary disease, the overall response rate was worse, and it was 47% only. So in further analysis, we found that factors independently associated with worse overall response rate included presence of extramedullary disease, poor performance status, and receipt of more than 4 lines of prior therapy. So in routine clinical setting, where teclistamab is administered later in the disease course, a significant number of patients have previously received other BCMA-directed therapies. The overall response rate in patients who had received prior BCMA-directed therapies in our cohort was comparable to the response of our overall patient population. The most common prior BCMA-directed therapy that our patients had received was commercial CAR T-cell therapy. Thus, for us, it was really encouraging to see that we can give teclistamab successfully after failure of CAR T-cell therapy. So despite achieving a similar response rate to the MajesTEC-1 trial, the MajesTEC-1 trial had actually higher rates of complete response or better and higher median progression-free survival compared to our patient population, reflecting the greater severity of illness in our patients. So it's important to note here that our study had a limited follow-up duration of only 3.8 months. And considering that the median time until a best response in the MajesTEC-1 trial was also 3.8 months, there is a potential for deeper and more durable responses in our patients with longer follow-up. So basically, while teclistamab was associated with early responses in a real-world cohort, durability and deepening of these responses need to be determined with longer follow-up. Apart from the efficacy, determining the safety of teclistamab in a severely ill myeloma patient population is of crucial importance. So in our study, the frequency and severity of adverse events closely mirrored those observed in the clinical trial. We did not see any new red flags or excessive toxicities. The primary side effects associated with teclistamab are cytokine release syndrome and immune effector cell-associated neurotoxicity, or ICANS. So the rates of this in our study were similar to those in the MajesTEC-1 trial. Most importantly, the rates of severe CRS and ICANS remained low at 1% and 3% respectively. In addition, all CRS events and all ICANS events except one occurred with the step-up doses or first full dose during the inpatient hospital stay and not in the outpatient setting, which was very encouraging. Also, the recurrence rates of these adverse events after management with tocilizumab and steroids were also very low. A total of 31% in our patient cohort developed infections, which is much lower than the 76% seen in the MajesTEC-1 trial. And this is most likely attributed to the longer median follow-up of the MajesTEC-1 of 14 months compared to just 3.8 months of our cohort. I think we would expect a higher rate of infections with longer follow-up if our patients stay on therapy. Notably, 3 deaths from infectious complications while in teclistamab were reported both in our cohort and the MajesTEC-1 cohort. Finally, we observed a 28% rate of readmission to the hospital after the initial ramp-up period, which most often occurred due to infections. So overall, in our study, teclistamab appears safe and effective in this heavily pretreated multiple myeloma patient cohort. While teclistamab was associated with early responses, as I said before, durability and deepening of these responses need to be determined with longer follow-up. The low incidence of severe CRS and ICANS seen in our study raises the possibility of safely administering teclistamab on an outpatient basis without necessitating hospitalization, provided that there are appropriate measures and resources and infrastructure in place for that. And this is also suggests that there is potential for teclistamab administration in the community by local oncologists, especially after the initial step-up dosing, given in a university hospital. However, at this point, it's essential to acknowledge that cytopenias and infections remain challenging aspects of this treatment. And for this reason, close monitoring and robust supportive care with prophylactic antibiotics, IVIG, vaccinations, and growth factors are crucial for patients to mitigate the risk for non-relapse mortality.